How are things?
All right. Good evening, everyone.
Good.
Welcome.
We had a good annual meeting at Harvard Medical. It was unbelievable.
Welcome to Contours Auditorium. Welcome to Burlington City Hall. It's great to have so many with us tonight. There are a few more seats down here. People should know there are also seats up in the balcony if you get tired of standing in the back. We really appreciate so many people coming out for a conversation that we haven't really had in this format for a couple years now. We had an opioid town meeting about 2 years ago, which I think was a really important night for our evolution in terms of how we think of this issue in city government and in the community. And we thought it was a good time to bring people back together and update you, and because a lot has happened in the last couple of years with respect to the opioid crisis in general, specifically what has happened here in Chittenden County and Burlington. And frankly, I think there's some hope now that you had to work really hard to find in the past. We are still, and it's still, we still always are aware that we are continue to lose way too many of our coworkers, our friends, our neighbors, our children. And at the same time, I think it's important that we recognize that the story of this epidemic is starting to change, and there is some hopeful news coming out of this region and in other parts of the country. We're going to try to kind of bring that update, have that discussion, get your feedback over the course of the night. Here's how we're going to try to do it. We're going to start with a conversation with these three national experts that we're very fortunate to have here with us in Burlington, and I'm going to introduce them in a moment. Later on in the program, we are going to bring a few more chairs out here, and we're going to bring up a number of local leaders, people who have been working on this effort from different perspectives. And there are so many people working on this effort, and many of you are in the room, and it was hard putting this program together to figure out who, the right set of perspectives to bring up here, and we could have filled the whole stage and more with people who are working hard on this. But we're going to bring them up to try to get a little bit of this interaction between our local leaders and our national experts, and then we will have time at the end of the program for questions, and we do have mics set up for that. Before we dive into that, and we're going to do it soon, let me just try to kick the conversation off by setting the stage as I understand it, and as I've come to understand it after really probably spending more time on this issue over the last 3 or 4 years than probably any other issue that we're grappling with because of the size of the challenge we're facing. This crisis began in many ways in the mid-1990s with the dramatic changes in the way opioid painkillers are being prescribed in this country, and the huge expansion of painkillers that were being dispensed in the community. But it wasn't really, in a lot of ways, until Governor Shumlin in January of 2014 sounded the alarm bell that we fully understood as a community, I think, that we were in a hot crisis that needed urgent action. Burlington took its first steps to really respond to that crisis appropriately, I would say, on September 1st, 2015, which was a day I always remember. It was a day that Chief Brandon Del Pozo, I hired him and swore him in on September 1st, 2015, and said publicly that day that one of the first orders of business was going to be to review the city's response to the opioid epidemic. I think we all sensed then that the city could be doing more. And what came out of that review was a realization that although there were literally dozens of different organizations in Chittenden County that were working hard to stop this crisis, they're working hard to save lives and to turn this around, that they're really, and even though the state was already well into what has continued to this day to be a massive effort to respond to the challenge, there was really no organization that was in charge of the local response. And as a result, there was no shared understanding locally about exactly what we were up against. There was no shared understanding of how the crisis was evolving, and there was not a shared consensus about what the right interventions should be to respond to it. And coming out of that review, the chief and I really came to the conclusion that the city could play a productive role into helping galvanize and lead and coordinate that effort. And we've been trying to do that in one form or another ever since. That effort really got some momentum going in the fall of 2016 when we hired Jackie Corbally, who's with us tonight. Where'd you go, Jack? Jackie's here at the back. And stood up this effort we call Community Stat, which is a monthly meeting where we sit down at a big U-shaped table, and you'll hear some reference to it at various times tonight. We actually just had a Community Stat meeting before coming over to this, and our guests joined us at that. And the principles of Community Stat are that we look at data, we try to deploy resources immediately to respond to what we identify as opportunities in this crisis, and then we relentlessly measure and follow up with those interventions and try to keep improving with each month. And about 2.5 years later, in part because of the work in that room, as well as the incredible work that continues to happen at the state level, and I do want to welcome AHS head of our Secretary of the Agency of Human Services, Al Gobey, and Commissioner Mark Levine from the Department of Health here with us tonight. And none of what we're going to talk about tonight at the local level would be possible, I don't believe, without real leadership and a remarkable effort from years now at the state level. But what has come out of the local effort, I believe, is perhaps the most robust constellation of interventions of any community in America. And as we meet here tonight, there is a sense that those interventions are starting to get some traction, starting to get purchase, and we are hopeful that the results that we saw in 2018, where accidental overdose deaths dropped by 50% in Chittenden County, we are hopeful that that is related to this local effort and that is something that we can continue. And we are doubling down on those efforts in many ways. At the same time, and one of the reasons for gathering here tonight, we know our work is far from done and we got a lot of work to do, and let's dive into the conversation to help shed some light and I think contribute to where we go from here in 2019. Let me introduce our panel of experts. So first, we're going to hear from Dr. Josh Sharfstein, who is the Vice Dean at the Johns Hopkins School of Public Health and the Director of the Bloomberg American Health Initiative and the author of the forthcoming book and topical book for tonight, The Opioid Epidemic, What Everyone Needs to Know. I will say it is remarkable, Josh's impact, not just on Vermont. He has been a major contributor to some of those interventions I mentioned before that we have been rolling out here in Chittenden County. He has also, for years, been helping the state grapple with and work with Al Gobey and others to set up our all-payer healthcare model. And it's really quite an impact you've had on the state, Josh. And it's a pleasure to welcome you here to City Hall. After the next, we're going to hear from Chief Fred Ryan, a 34-year veteran of policing and recently retired chief of the Arlington, Massachusetts police force, where he was the chief for 20 years. A stat that did cause some nervousness, I understand, over at 1 North Avenue, and the idea of a chief being around for 20 years was mentioned. He has been the co-chair, in addition to his chief duties, he's been the co-chair of the National Police-Assisted Addiction Recovery Initiative and a national leader in small and mid-sized police departments' addiction and recovery initiatives. And we're very appreciative you're here, Chief. And third, we're going to hear from Gil Kurlikowski, who served as America's drug czar under President Barack Obama, and then was the head of the U.S. Customs and Border Patrol. We're going to get a chance to get into some of the conversation that we hear a lot about right now. It's very much on the minds of Americans. To what degree does this debate we're having about the border and how we how we resource the border contribute to this epidemic. Prior to his federal service, Gil also has a background as a police chief. He was a police chief in Seattle, Washington. So it's a privilege to have all three of you here. We're going to start with approximately 10-minute opening remarks from each speaker, and then we're going to go from there with some moderated discussion. And I'm going to try to serve that role through the evening. So come on up, Dr. Sharfstein.
Thank you so much, Mr. Mayor, Mr. Police Commissioner, and all of you for having me here. So I am from a school of public health. I've worked as a health commissioner at the city and state level, and I talk all the time about approaching problems as if they're public health issues. And so what does that mean? You probably heard that phrase, we should think about opioid addiction as a public health challenge. What does that mean? So our school that I come from is the first school of public health in the world. It was actually created when the kind of concept of public health came into being. And the most important thing to understand about public health is that it is focused on the health of a community. So my number one point about what it means to think about the opioid addiction as a public health challenge is you have to think about meaningful outcomes that matter for people, and you're trying to reduce the pain and suffering that communities are feeling. And that means you're looking at overdose deaths, you're looking at the number of people who can put their lives back together, take control of their lives again, go back to work, put their families together, all the things that really are meaningful. And you're not distracted by maybe preconceptions or stigma or measures that are things that we've always counted, but maybe you might wonder are whether they're really linked to the fundamental outcomes you're trying to address. And so something that would come to mind there might be the number of arrests. Is that a fundamental outcome, or is that just something that has been done but may or may not be linked to an outcome we really care about, like the number of people who are dying? Number two, to actually improve outcomes, a public health approach is going to look at evidence. What works? And when we look at evidence, we try to bring really no politics, no preconceptions. We look at the data, and we look at multiple types of data. And the data on opioids is that there are things that can work. I could talk about a number of them. I'll talk about one, which is treatment. Treatment can be very effective, particularly treatment that includes medications like methadone or buprenorphine. And how do we know that from studies? We know that from many, many individual studies where some people get medicines and other people don't, and the people who get medicines do much better. We also know it from when entire cities like Paris or Baltimore expanded access to treatment, and they saw a substantial drop in the number of people who were dying. Most recently, there's really good evidence that when emergency departments can start people on treatment, that the rate of success doubles. Than if they just referred and gave a phone number. And there's very strong evidence that when jails and prisons provide treatment, that people are much less likely not only to overdose, but to commit crimes again. And now I talk about this evidence in a lot of different places, but I'll tell you what is most helpful to me in communicating about the value of treatment is the story I tell about my wife. Okay, my wife is an addiction medicine doctor, and I'm a pediatrician, and we met in medical school. And when she told me, my medical school girlfriend, now my wife, told me she was going to go into addiction medicine, I thought it was like she was telling me she was going to be an oncologist just for patients who were going to die. And I thought, my girlfriend is a saint. That's what she is. I really had no idea. And I thought, she is just going to be awash in misery, and I am going to be collecting gifts from all the parents of the kids that I'm taking care of. When the holiday season comes around, they'll give me some things. And turns out, parents are pretty busy, and I probably wasn't that good a pediatrician when I was in practice, and so I never really got a gift from any family. But my wife takes people who are absolutely in the most extreme condition and works with them, helps them, empowers them, treats them, and they move off the street, they get housing, they get their families back, they start businesses, And if you come around to our house at holiday time, she gets so many different gifts every year from people she's incredibly close to. So to me, I could quote a whole bunch of studies. That's the story people understand, and it's completely true. And I've really been inspired seeing her to understand what happens when you really can apply science to this problem. Number 3, public health is about prevention. So we're always trying to think how to prevent challenges like this. And obviously, as you heard from the mayor, the prescribing problem contributed substantially in a lot of parts of the country, including in Vermont, and really thinking about how to have thoughtful approaches to prescribing that, and particularly better options for pain than opioids, so people can really get their pain addressed without using opioids that ultimately may not be that effective for a lot of people, is a really important strategy. And if you go a little bit further back, I think one of the most important things is to look to support young people who are really at risk for not being connected to school or work. And I think about adolescence as a major transition point where people can either be on their developmental trajectory, be in their life path, be moving towards education and jobs, or fall off that path and have all sorts of problems, including addiction. And I think, those sort policies, programs, schools, and jobs that are really focused on high-risk adolescents, preventing them from becoming disconnected and helping them as soon as you start to see signs of problems is really important in preventing opioid addiction. Finally, the fourth one I would mention is to listen to people who are affected by the problem and take what they say and try things that are different, innovate, and check to see whether it's working. Public health is constantly about a cycle of trying new things, looking at the evidence, see if it works, try it again, and really basing those innovations on what you hear from people who are really experiencing the problem and on the front lines. And that's where I was so impressed to hear earlier today at such an important and interesting meeting about the low barrier access to treatment that people have access to through the syringe exchange and other places, because people were going for years to the syringe exchange saying, I wish I could get treatment right now, and there was nothing to offer them. But because of the way Burlington responded to them, there's now treatment there for them, and so many people are doing well. There are many other kinds of innovations that people can think of. Innovations in law enforcement. Public health, perhaps because it's so new, we generally are ready to rethink traditional approaches. And what your police department's doing is rethinking some traditional approaches to policing around drugs. And now, is every non-traditional approach going to be successful? No, but a public health approach would be, let's try something different. Let's think through what's actually going on. Let's not take the approach of just because we did it one way, we'll have to do it that way. And we may try something different. For example, not prosecuting people who may be with small quantities of a treatment medicine in their pocket, when that actually is going to predict they're going into treatment. And that is something that can be based on listening to people about how they're using medicines in ways that can actually save their lives. There are other approaches that have been developed. I know that there's interesting approaches to testing for fentanyl in ways that can actually help reach out and engage people who are really at high risk and help them realize not just that they should test their drugs for fentanyl, but that they can actually use that connection to ultimately get into treatment that can save their lives. So I think, as I think about these 4 points that I made for a public health approach, focusing on outcomes that matter, looking to evidence, preventing, and listening to people and innovating and checking the results of that, I really think an important reason why Burlington is making progress is because you're taking a public health approach. I'm really pleased to be with you all here tonight. Thank you.
Thank you, Mayor. Thank you, Doctor. Chief Del Pozo, the men and women of the Burlington PD, thank you for having me. My name is Fred Ryan, as the mayor said, recently retired police chief from Arlington, Massachusetts. I'm still adjusting to not being a police officer, so I think I got a ticket in front of the PD today for a meter violation, Chief. I don't have a driver anymore, so I'm navigating my way around the city. I also serve as the co-chair of the Police Assisted Addiction Recovery Initiative, which is a private nonprofit organization made up of approaching 500 law enforcement agencies in the United States, all of whom engage in some form of pre-arrest diversion approach to opiate disorder in their jurisdictions. And you might ask, typical white Irish Boston cop, right? How did my career over 34 years bring me to a place where I started a nonprofit? Well, first of all, I failed miserably as a drug cop. They took me and put me in a drug unit when I was a young police officer, and I look and act like a cop, so I couldn't get anybody to sell me drugs. I quickly found myself back in uniform. But I was one of those uniform police officers that was out there, making arrests and making street-level drug arrests and arresting oftentimes the same people. And even early on, as a young cop, when my supervisors were encouraging this type of activity, I wondered, what am I achieving here? Are we moving the dial, or are we just, recycling and wasting resources and not getting at the root cause of the problem? Fast forward, as I got promoted up through the ranks and became chief of police in my jurisdiction, early in calendar 15, we were losing about one person a month. And we're a small jurisdiction, about 50,000 people next to the city of Boston, very densely populated, about 5 square miles. And, I started going to the funerals of my friends and started wondering, what could we be doing differently here? And then we had a case that came across my desk. It involved a young lady by the name of Keller. And Keller was beautiful in every sense of the word and successful, by any standard of success in America. A graduate of the University of Massachusetts. Her mom was an educator, her dad a firefighter. And Keller overdosed, and her family accessed 911. We sent police officers and EMS out, and we reversed that overdose with Narcan, and we brought Keller to a Boston area hospital. 7 days later, 911, Keller had overdosed. We responded, we reversed that overdose. We brought her to the same Boston area hospital. 7 hours later, 911, and Keller was dead. And when that case crossed my desk, it screamed of failure. Failure at the front end of the process, at the law enforcement level. I was asking myself, what could we have done to prevent this young lady's death? And so we went back and we reconstructed that case with the authorization of her family and the healthcare providers. And what we recognized was that the systems were flawed both at the public safety side as well as the healthcare side, and that we needed to do a whole lot of work around changing the paradigm around the way we approach addiction in our jurisdiction. And that was sort of the case that became the catalyst that motivated me to implement change. And so as we sort of sat around the table and strategized about, what is it we can do better, and, our crime analysts put up a spreadsheet at one of our ComStat meetings, and, any chief that succeeds for 20 years, Chief Del Pozo, little advice, you surround yourself with really good people. And she pointed out, she said, Chief, I think we know who the next overdose victims are in our jurisdiction. And I was shocked by that. I said, who? And she said, well, they're right here on the spreadsheet. These are people who have previously overdosed, and they're at high risk of fatally overdosing. And the question became, what is public safety or public health doing to prevent their mortality? The answer was nothing. And so that was the point where we changed our approach in our jurisdiction. We embedded clinicians into the police department to begin to do outreach work with that known population of people suffering with opiate disorder, and developing a protocol, a post-overdose protocol, where our outreach workers would go out and do some survival planning, give the person in the grips of addiction Narcan and other resources, harm reduction resources. And that was sort of our handshake. And then our clinicians were very savvy at getting access to others invested in this person's health and wellness. And the mindset that we tried to bring to it was this: survival plan for the next overdose. That's precisely what we would say to the person suffering with substance disorder and their loved ones. Let's plan for your next overdose, as absurd as that may sound, so that we can ensure your survival. The second prong was our clinician would begin to work with families to educate them around the science of addiction, because there was a lot of misinformation out there about the science. And the clinicians would teach families and patients around the medication treatment therapies, 3 federally approved therapies available to them, and then build an intervention plan. And the mindset we try to bring there was, let's treat this no differently than if your loved one was expecting a child, right? If your loved one was expecting a child, you'd have a plan. You'd know who the healthcare provider would be. You'd know, what health insurance, what facility you're going to, who's going to drive. You pack a bag, get the cigars, get the balloons, whatever we need to do to have a plan in place. No different than somebody who's expecting a child, so that when your loved one is ready to ask for help, you don't begin the planning then because you've missed your opportunity, it's too late. So in doing that outreach and that work, along with a number of community meetings and events such as this, and I commend the mayor for doing this, and getting the dialogue going in the community around addiction and the complexity of addiction and the therapies available to folks, we started to drive down the death rate in our jurisdiction. And I'll close with stigma. The mayor and the police chief and Grace and others in the city, I sat in a meeting earlier, I am so impressed with the work that's being done here in the city of Burlington. But success can't happen without everybody in this room and everybody in the city creating an environment where long-term recovery can happen in the community without stigma. Oftentimes detox occurs in a healthcare setting and a private locale, but long-term recovery occurs in the community. And if we continue to stigmatize and label those suffering with substance use disorder, we'll continue to meet with barriers to success and self-imposed barriers to success. So my message to you here tonight is no different than the conversations we have around bias and racism in the community. When you hear the term junkie and the stigmatization of people suffering with substance disorder, don't accept it, stand up to it, embrace the work that your city's doing and the state's doing, and move the dial around addiction in Burlington. Congratulations to you all, Mayor. Congratulations to the city. I'm happy to work with you all. Thank you.
Good evening. This is what you call batting cleanup after 2 really exceptional individuals, and listening to the mayor kind of set the tone. So a couple things that I'd like to express to you. I was President Obama's drug czar for the first 5 years in office. I'd been the police chief for 9 years in Seattle. And I wanted to set a little bit of the historical context for you around the opioid issue. It is unique and devastating crisis in the country. So in 2008, shortly after the election, I had been called by the Vice President-elect's office, Joe Biden's office, said, we'd like to talk to you about the drug czar position. Well, I'd been a police person all of my life. I knew something about law enforcement. I actually worked in narcotics and was able to purchase drugs once. But maybe that was my expertise. But I knew nothing about prevention, nothing about treatment, nothing about recovery, nothing about understanding this. And so when they said, look, we'd like to talk to you about this, I said, gee, wouldn't it be nice if we could talk about something in enforcement? And the person kind of laughed and said, you don't understand. What you're interested in is of no concern to us. We only care about us, and this is what we want to talk to you about, and I'm so glad they did. So I was nominated and confirmed by the Senate to take that job, and started in May, shortly just after the inauguration, a couple of months after the inauguration. I was getting ready to leave the Seattle Police Department. The captain in charge of narcotics, and I remember this is early 2009, he said, you know, Chief, we're seeing a lot of these pills out here, opioid painkillers, and he said, you know, we're not quite sure what's going on with this. I said, oh, that's interesting. I had no idea. Well, you know, as a police person, you know, police chief, officer, you take a sworn oath of office to protect the people you serve. If they're dying, if you're not protecting them, then, you know, you're not really doing your job. So then the head of a federal law enforcement agency in Seattle came to me and he said, hey, I know you're getting this job. You're moving to Washington, D.C. from Seattle. He said, I want to tell you about painkillers. He said, I have a son. He should be a high school senior. He's in drug rehab. As a junior varsity football player, he had an injury. He was prescribed opioids and became addicted. Pretty common story. And I said, you know, I really knew nothing. So we made it a signature issue. And I want to tell you a little bit, the Office of National Drug Control Policy was created in the 1980s after the death of a University of Maryland basketball player who had been the first round draft pick for the Celtics. And he died of a drug overdose just outside of Washington, D.C. And so it caused a lot of questions about what is the United States, how does the United States respond to a drug problem, a drug crisis, cocaine then, we saw methamphetamine, et cetera. Well, you couldn't open the book for these hundreds of millions of dollars that are spent in the federal budget and say, well, let's look at the line items. You can look at your city budget and you can tell how much money is spent in different places, but you couldn't tell at the federal government level. Well, the Department of Defense spends some money, and before Customs and Border Protection or the Border Patrol on drug interdiction, and the Drug Enforcement Administration, et cetera. Well, I came here a number of years ago with Senator Leahy, and as members of Congress like to say, they like nothing more than to sit on high behind a dais and then point their finger at somebody and say, you're responsible, you're accountable, what are you doing about it? But if you were to do that with the hundreds of millions of dollars that are spent on drugs, you couldn't. You'd say, well, we'll call in the head of the Drug Enforcement Administration, we'll call in the Justice Department prosecutors, we'll call in Health and Human Services on the treatment end. You just couldn't find anything. And so the push was on then to say, we're going to create a White House Office of National Drug Control Policy. And for want of a better term, the term is czar. But it's actually quite a powerful position. It is the only position other than the president and the head of the Office of Management and Budget that you can decertify a budget of the Department of Defense or the Department of Justice. Say, you know what, you're not really doing enough on the drug issue. We're going to decertify your budget. That's incredibly powerful when you have the purse strings. You're reporting to the president. And so the office was meant not as an enforcement arm, not to go out and solve the problem by seizing drugs or getting people into treatment. It was meant to coordinate all of these hundreds of millions of dollars in these diverse different parts of the federal government under one auspice, the President's National Drug Control Strategy, which he has the letter on the first page. It's authored and it's signed by the head of the Office of National Drug Control Policy, and it said, we need to bring all of you together so that we're not going to be redundant, we're not going to have overlap, and we're going to support each other on prevention, on treatment, on the training of law enforcement personnel, on enforcement, on working with other governments around the world about the drug issue. So it was an incredibly fascinating time to come in because I think you couldn't count on both hands the number of articles in 2009 about opioids. It was an issue, it was known, but it really wasn't anything that you're going to read in a local newspaper or you're going to see much about on television. And now, look tonight. Look at the city. I mean, the number of people here and the amount of interest that you're generating about the opioid problem, the opioid crisis, because it has impacted everyone in the United States. I have never spoken to a person who hasn't known somebody in school, a friend, a relative, themselves, others, that has not been severely distressed, severely impacted, or even lost someone or lost multiple someones as a result of opioids. But it is an incredibly complex problem. It isn't solved at the federal government level. It's really solved like right here at the community level. And when I saw the reduction of the statistics, I saw the leadership of the mayor, I saw the leadership of the police chief, and all of the people at the table today. I think Chief Ryan and I could often be called sometimes cynical because we've spent a long, long time in law enforcement. I don't think we couldn't have been more heartened by what we saw today and the work being done. And then to see this tonight and to see all of you here expressing interest, taking time out of it and realizing that you really are making the difference. So thank you for having me.
All right, great. We are oddly on schedule, which rarely happens. We got about 20 minutes now where I'd like to kind of build on just the remarks you each gave, have a few questions for you, and then we're going to bring some other people in the conversation. But, you know, I appreciate where you ended there, Gil. It was great to have the three of you with us at Community Stat at the police station earlier this afternoon. We had a couple hours where we were able to kind of lay out for you this low barrier buprenorphine initiative that has been running since October now at our needle exchange, where people have the opportunity to basically a facility that many of them have been going to for a long time to exchange clean needles. We have added the service of people immediately being able to go to start receiving this life-saving medicine, buprenorphine, there before they leave. We talked about a similar effort now happening at the emergency room up at UVMC, where that emergency room is one of just a handful, I believe, in the country still, where most of the emergency room doctors and many of the physician assistants now have gotten the waivers that they need to and can prescribe buprenorphine in the emergency room. And every person that is coming in for any reason is getting some level of screening, and that is starting to show as a promising strategy. We have this since last July. Vermont prisons have also been a place where people can start getting medically assisted treatment. You heard of an effort that we're hoping to stand up in a few weeks where the police are going to be taking on a new role. You had a chance to sit there with the dozens of different providers that are involved in this effort in one way or another. I'd love any reactions you can share with us, where you think if there are municipal, local level strategies, because I agree with you that I think this is, the local communities have a lot to do with impacting this. Are there things that are missing in our approach? Are there reactions to this for improving it further that you came out of that meeting having?
Sure. Let me start for a second. I think the most important thing to kind of recognize, the mayor is an elected position, isn't it?
It is elected. Fortunately, don't need to be reelected for a couple of years now, but yes, it is a...
Oh, good for you. There are a number of elected officials that will try and give you a pretty simple and direct answer to what in the opioid issue is an incredibly complex problem involving the pharmaceutical industry, doctor training, the Commission on Accreditation of Hospitals, and the pain management, the lack of any type of curriculum for new doctors, although now Massachusetts, I think, requires a certain amount of training. It takes a great deal of courage for an elected official to hold a meeting and say, let's talk about this in the depth and with the complexity that this problem deserves, rather than try to give you kind of a shorthand, simple answer to what is an unbelievably difficult situation. President Obama used to say, you know what, if it was easy, it wouldn't be on my desk. And it's on your desk and it's hard. Congratulations.
The only thing that I would add is I was heartened to see the medical center staff there. You know, I talked about Keller and a Boston area hospital, and although we've improved, you know, that Boston area hospital kicked Keller to the curbside, you know, released against medical advice is what the documentation said. But the reality is that hospital at that time didn't have the desire or the capacity to treat an overdose patient. They wanted to free up the bed and move on to the next case. So to see the medical center involved in such a meaningful way, I think is huge. And there's no more important time in the history of our country for public health and public safety to come together than now. Third year in a row, Josh, that our life expectancy has gone down, largely due to opiate disorder and mental health. We've got a country in despair. It requires the partnerships that we're seeing. Outstanding.
Yeah. I would say what struck me was the incredibly focused discussion on what would really make a difference for people, and that respected some basic aspects of opioid addiction. You know, people who are addicted to opioids will go into withdrawal every certain number of hours. If it's heroin, it's every 6 to 8 hours, and they will need another dose to avoid a very, very painful, horrible withdrawal. And so if you say to someone, I really want to help you, here's a number, you can get an appointment in 2 days, you're basically sending them out probably to use 4 to 6 times in that period. And by then, who knows whether they'll still actually go to treatment. And so when people come in to the syringe exchange or to the emergency department and are ready to start treatment, you don't want to let them go into withdrawal, and you don't want to, you know, give them a 10-hour assessment. You don't want to tell them the waiting list is a year or even a few days. You want to treat them right away, and it's that recognition that, you know, that's so important. What I really appreciated, particularly coming from the medical center, was that they realize that it's their job, that it's a medical condition, and that they can really make a difference by providing timely medical treatment. And I think one of the physicians said, you know, if it were diabetes, we wouldn't send someone out and say, here's an appointment in 3 days. If we need to save their life now, that's what we would do.
Well, I appreciate that you both picked up on that. I think we are very fortunate, and I know a number of people from the medical center are here, and I do think UVMC has for years now really taken on the challenge of viewing this as a disease, as a public health epidemic, and really tried to make good on that notion that if this is a disease, we need to treat it as such. And I find that is helpful in other areas. We talk a lot about buprenorphine, this medication, and one of the things we have been promoting is thinking of this as something akin to a medicine that's like insulin for diabetics, and that it may be something that people need to be on for a very long time and shouldn't be treated as a sort of dangerous substance in itself to urge people to go off of. I think both those realizations speak to something you were talking about, Fred, and that I think is a main purpose for having this event is the stigma still looms very large in this country, and even in a community that's been grappling with this for some time, like Burlington and the state of Vermont has. I am stunned by the anger and the venom I hear directed towards people who are suffering from these powerful addictions to this day, even after years of this discussion. Can you I think the hospital treating this like a disease is a destigmatizing action. Are there other examples of that sort of change people's frame and that you think we should kind of hold up as actions that communities can actually do to destigmatize this disease?
Well, one thing is access to federally approved medications. You know, in Massachusetts, only 4.5% of the treatment providers provide all 3 federally approved therapies for opiate disorder. I mean, that's a problem, right? And the other thing is you know, some of the harm reduction strategies that have been employed, you know, where else do we make people wait in line out on a city block to get their meds, but at a methadone clinic, right? And in Boston, we have what's known as a methadone mile, which enhances the stigma associated with addiction. And I've told Grace this story. The Boston Globe did a story on methadone mile, and they had a photo intended to perpetuate the stigma. It was two young men using in an alleyway. And to the untrained eye, that looked terrible, two men using in an alleyway. But when I looked at that photograph more closely, and others looked at it more closely, what we saw was hope. There was clean works. There was a steri-wipe that those that were using had used to clean the site before injecting, and a number of other pieces of evidence in that photograph that demonstrated hope and that the city was making a difference. But the point is the media missed the point. They, in their intent to further the stigma, really what, to a trained eye, it showed that, wow, our harm reduction strategies are working.
So we had a meeting in Washington, D.C. A couple of your Burlington team were down there. Chief Del Pozo and Grace was there. And we also had, in that meeting, where we heard about low barrier treatment, there was a group there from Huntington, West Virginia. Huntington, West Virginia has been just so severely impacted by the opioid epidemic. And we had one of the lead EMTs, ambulance workers there, and the mayor. And they were talking about a program where they provide mental health support to the EMTs and to people who they're resuscitating, and how it came about. Because this epidemic is traumatic not just for the people who are affected by it. It's traumatic for family members. It's traumatic for caregivers. It was unbelievably traumatic to the ambulance workers in Huntington. People there talked about having to respond to overdoses of 4, 5, 6 of their high school classmates. And what the mayor said was that he was just incredibly shaken by the way that people were defending themselves against that trauma. They were, not being very caring. They were saying things like, here we go again, another overdose, how many times do we have to go back out? And that was really reflecting just a tremendous desperation and pain that the actual caregivers were feeling. And one of the focus areas they did was to talk to the EMTs, to give them support, and then they actually deployed mental health workers on the ambulances, both to help the EMTs and to help people who were being resuscitated. They found more people going into treatment, and it was actually much more inspiring for the EMTs to know that their activities were making a difference.
Just a quick message. When I picked and recommended a deputy to be Senate confirmed to be the deputy director was Michael Botticelli, who's in recovery. He's been in recovery 30 years. Office of Personnel Management in the president's office is designed to do one thing: protect the president. Don't have somebody that you're going to recommend, its name is going to be out there, that is going to embarrass the White House. And they said, you're recommending somebody that's in recovery, that's gotten in trouble, and it was many years ago, and but went on to have a successful career and on and on. And the Senate confirmation process, not everybody gets along in that process. That's just the rumor that I've heard. So Michael, the president supported, nominated Michael. Michael went through Senate confirmation glowingly. It was just amazing. I could never understand. I couldn't get on the front page of the Wall Street Journal or any other paper. Michael could do it. He got all of these things. They just loved him because actually he'd been there and he'd seen it from the ground up.
Well, we don't always get along in hearings here at the local level either here, but we do work hard to try to move the community together. I am really pleased to see how many city councilors have joined us tonight, and do want to welcome Councilor Pine, President Wright, Councilor Busher, Councilor Karen Paul, who's been a real leader on this issue, and Franklin Paulino, who will soon be joining us, and Councilor Ali Jang, I believe, was here. He might have stepped out for a moment, but that is the fact that our city council has been very much on board with addressing this effort has been a big part of the story here in Burlington as well. So I want to shift gears slightly. Just let's hit a couple kind of hot topics, and then we'll bring in the rest of our panel tonight. We are having this incredible national debate about immigration, and in particular about putting up increasing the amount of wall that we have on the border. There's been the notion, the explicit argument made by our president that would have an impact on the conversation we're having tonight, that would reduce the amount of illicit opioids and drugs in our community. Gil, can you speak to that argument and how you see it, and how you specifically how the mall would impact the opioid epidemic?
So the wall would have almost zero impact on stopping drugs coming into the United States. The drugs that are killing people, heroin, fentanyl, methamphetamine certainly, and cocaine is on the rise, come through our ports of entry universally, whether it's JFK or Los Angeles or San Ysidro or very small ports. And it either is hidden in vehicles or it comes in by people bringing it in. They do not backpack it across the border. They don't try to sneak across the border. The only drug that comes across the border on the southern border is marijuana. Marijuana seizures on the southern border have gone down for 8 or 9 years. We have 10 states that have legalized marijuana, and there is marijuana grown in hydroponics and a number of other places. So it's not a particularly big issue. But I testified 3 different times, 3 Senate hearings, including New Hampshire. And the question was asked, well, if we could just interdict more drugs, then we could reduce the amount of the drug problem here in the country. So the same analogy to interdicting more drugs and reducing the amount of drug use would be that if you want to reduce the number of diamonds in the United States, you just need to seize all the lumps of coal.
Safe to say Gil enjoys retirement. He won't be getting called by the administration anytime soon.
Now, I'd love to get all your thoughts quickly on a big debate we're having here in the state, which we have a lot of consensus in the state about this being the opioid epidemic being a top public health priority. We have a lot of consensus that the hub and spoke system that has been pioneered here in Vermont is working and needs to be expanded. And a lot of what we're doing, I think, is here at the local level is trying to leverage that hub and spoke model so that it helps as many people as possible. But we are having a debate this year as one of the, and it's I think a welcome debate that it's good to hear from both sides on this over the current, whether the possession of non-prescribed buprenorphine should be prosecuted as a crime here in Vermont, and whether it should, and I would welcome your perspectives on that from both a law enforcement and public health debate. I think there are people who believe we should continue to enforce it because it is the right thing for public health. I'd welcome your perspectives on that. I do want to say we are joined by the state's attorney, Sara George, who's been quite courageous, I believe, in being one of the first and only prosecutors in the country to say she will not prosecute for non-prescribed buprenorphine possession in Chittenden County. And we are joined by Selena Colburn, who I think has been the lead sponsor on this bill that is being debated, and it's really unclear what the outcome is going to be. And I think you could help the community by sharing your thoughts on that.
Sure. So I would say my opinion is informed by a few points of data. There are a number of studies about non-prescribed buprenorphine in the United States and why people are carrying it, what they're doing with it. Very rarely is it used for euphoria, but people generally don't, feel euphoric when they take it. It's almost always used to prevent withdrawal. People just don't want to go into withdrawal, like I said before, and so they will take buprenorphine. One of the interesting findings is that use of buprenorphine that's not prescribed predicts wanting it for treatment and showing up in treatment and actually being successful in treatment and being able to put your life back together. We actually heard earlier today from an emergency room physician here in Burlington who said he's had multiple patients come in seeking treatment after trying buprenorphine that they had gotten. And so you put those facts together and the data that I've seen, and I think it is what, in public health, the key question is compared to what? If there was no opioids anywhere, would it be good that some people are carrying around buprenorphine that's not prescribed? You'd want to know why they were doing that. But that's not the world we live in. The compared to what is people actually using much more harmful opioids. And to the extent that people will use buprenorphine to prevent withdrawal, they're not using more harmful opioids, and then they're more likely to go into treatment, you wind up with a positive benefit for people doing it. And so for that reason, I personally would be supportive of the measure that's been introduced. And I think if you look at some other countries and how they pursue this, they make it very, very easy to get treatment drugs, much, much easier than in the United States. People can wander into an overdose prevention site in Barcelona and just get a day's worth of methadone right there. And I think, and what they tell me when I talk to them is someone will wander in on Monday, then they'll wander in on Tuesday. I don't feel like using heroin today, I'll just use methadone or buprenorphine, and then by the end of the week or maybe the next week, they want treatment. They're ready to move. It is a pathway to recovery, and I think what the legislation is seeking to do is to use evidence to support, like I said before, an innovation that makes sense, and then you want to do it and then see whether it works.
Excellent.
I agree. Enforcement and prosecution of possession of buprenorphine is a distraction. Fentanyl-laced heroin is killing people. That's where our energy and our focus needs to be in getting people access to evidence-based, patient-centered treatment. That's where our focus needs to be.
I don't need, great.
Excellent. All right, well, excellent. Let's, I'm not quite sure how this is going to happen, but I think we're now going to shift gears here, and some chairs are going to materialize, and we're going to open up this conversation. So if you are part of the panel, come on up, and great.
I don't know.
I'll follow you.
Oh, I was going to help.
I actually grew up in Lexington.
Oh, really?
Yeah.
Okay.
Yeah, my dad grew up in Lexington.
I guess I'll just stand.
A woman from Seminole Ladies Office.
I think we need a few more.
Yeah, there's a lot of transplants.
Yeah.
I know. Unless
Chairs.
Good room, great though.
Good, Chief. Your guest.
Well, and we started today.
I don't bite.
On the camera. Right in the day. I
There's a clear study of my pores for sure.
What do you do?
I'm the director of neurology and psychiatry up at the medical center.
more chairs.
Fascinating. How long have you been there?
16 years.
Oh, my God. Thinking of making it a career, or are you still?
Okay.
Doing good. Doing well.
Great. Okay. We're going to dive back in. And in the interest of time, we will introduce people as we go here. And what we were hoping is that each of the local experts, leaders who have just come up could, if there is one thing you've heard from the conversation tonight, or most of you, or if not all of you, were at the conversation earlier today, if there's anything, any reaction, any lesson from our national experts, or just reaction from what's going on locally that you want to make sure the public kind of takes home from today, now's your chance to share it. So let's start with Dr. Kimberly Blake, who is, you've heard reference tonight a couple times to this new program we have at Safe Recovery, which is our needle exchange site, where we are now prescribing buprenorphine, this life-saving medicine, to people in the needle exchange site for something that has only been possible since October. And a main reason that this is possible is because Dr. Blake has joined the team and is providing that service. So we're really thankful, Dr. Blake, for the pioneering service you're providing, especially as someone whose family has been impacted by this crisis. So thank you for being here tonight and sharing your thoughts.
Thanks. What a great forum tonight, and I'm so excited for our community that we're having meetings like this and ComStat. Sorry, not much of a public speaker.
Well, it's these mics. Everyone should know you really have to speak straight into them or they don't register very well.
I'm a longtime Burlington physician. My son passed away from an overdose about 1.5 years ago, which is still a little bit hard to talk about. But I think there were a couple of take-home points that led me to be interested in working at Safe Recovery, and probably the biggest thing was the research that I read that study after study shows that people who visit a syringe exchange would take treatment if it were available. And the idea that I could offer my capabilities as a physician to provide treatment on site. I know that 77% of people seeking syringe exchange materials would take treatment if it were offered. And that's what I found, is that people come in sometimes after a recent overdose. Last week I saw someone who had seen his friend die that day, and he sought treatment. It's very empowering to be able to do something for somebody when they're in that moment of wanting treatment, and that has been a big, powerful message that I hope that everyone could hear. The other piece that I think that is really very important is that stigma is dangerous, and it is a reason that a lot of young people are not seeking treatment, and the more that we can do to reduce that stigma, the better. Finally, I appreciate the thought and the knowledge that buprenorphine is a very safe alternative to what's out there. Most of my patients who come in are testing positive for fentanyl when we do their urinalysis, and that's a very dangerous situation to be in. So I'm really grateful that we have something that's a safer alternative. Thanks.
Excellent. Next, we have Grace Keller, who is the director of Safe Recovery and has been for many years and has played a key role in standing up this new effort. So, Grace, welcome.
Hi, thank you. I would react to similar things that Dr. Blake reacted to. When we're talking about people visiting a syringe exchange, what the secret to syringe exchange that people don't know automatically is that it's a great conduit to treatment and recovery. And for a long time, we had the esteemed recognition of being the program that put the most people on the waiting list. And we put more people on the waiting list every year than any other program in the state. And then we moved towards being the program that got more people into medication-assisted treatment in the state. And we got 228 people in 2017 into treatment. But those, even with no waiting list, we still had a little gap in time, and at that time people were using fentanyl in that gap, so we really wanted to fill it. We also knew that the waiting list wasn't the only barrier to treatment, so we really wanted to wrap these clients in a lot of services and make sure that we were there when they decided they wanted help, the system was ready to help them, and we could help them immediately. So as Dr. Sharfstein said, you want to give treatment to people when they ask for it in that moment, because that moment can be fleeting, and when that moment can be fleeting, it also can result in death. So we worked really hard to make sure that we're giving people treatment in the same hour most times that they ask for it. At times, we've had the police drop people off and get them into treatment immediately, and it's really been working. And the reason we did that is we knew from what we've seen in our practice for a very long time that would be effective, but that's what science tells us would be effective also. So I think the way that we move forward at Safe Recovery and the way that dictates our life all day, every day, is focusing on science and compassion. And I think through those two ways of looking at this, and compassion is where stigma comes in. I mean, we really have to look at people as human beings and give them the dignity and respect that they deserve. Our clients are survivors. They've been through more than any of us in many cases. I had clients that came in last year, and we hadn't seen them in 6 months, and I asked them, "Where have you been?" And they said, "We've been in recovery this entire time." And I said, "Did you find a safe place to live?" And they said, "No, we've been in a tent." And they've been in a tent all winter long, getting up out of that tent, unzipping it, and walking all the way to the clinic every day. And that's resiliency that we need to see in this population as a public. We need to be looking at these, at folks and seeing them as survivors. And like Dr. Sharfstein said, listening to what they say is going to help them. And so when we're in the syringe exchange, we know what we're asking them when they want help is they want help now. So that's really what we've worked on, is reducing stigma and making sure our services are anti-stigma and getting people treatment exactly when they ask for it within the same hour, same day. So thank you.
Excellent. Okay, next we welcome Sara George, our state's attorney, who in addition to being a leader on the debate we were just discussing about buprenorphine, has also really spearheaded the conversation in this community about safe injection sites, and we're welcome you've been here tonight. Sara.
Thank you, Mayor. I just wanted to kind of say briefly a couple of things. One, I think that within law enforcement, both by prosecutors and by police officers, we imagine that our job means to enforce laws, and over the 8 years I've been a prosecutor, it's become clear to me that our job really isn't necessarily to enforce laws, it's to protect the public. And too often we forget that the individuals who are using drugs and people with substance use disorder are just as much a part of this public as you and I are, and that we have just as much responsibility to protect them. And when we made the announcement that I wasn't going to prosecute individuals who were possessing misdemeanor amounts of Suboxone, there was pushback from law enforcement on that, and I think with really good intentions, a lot of the law enforcement officers in Chittenden County anyway have the idea, and I think based on how our system has worked, that we need to arrest people in order to get them treatment. And frankly, that has been the case in a lot of the time I've been a prosecutor, that if we want to get people treatment, we need to arrest them because it's the only way to force them to get it, or it's the only way that they'll have access to it. And frankly, this new program, I think, just completely negates that need. We don't need to arrest somebody in order to get them that treatment anymore. And in fact, we want to encourage people to possess a drug that will save their life versus the possession of heroin that is likely to kill them. And I've talked to multiple police officers in Chittenden who have come into contact with somebody who did possess a strip of Suboxone illicitly, and they were able to not only tell them about the new programs that we have at the ED or at Safe Recovery, but actually bring them there and get them a valid prescription. And in my mind, that is true public safety. That is exactly what law enforcement's job is in that moment. And they have been really not only receptive to it, but really glad and proud to have been able to do it because they saw that person have a moment of hope and access a medication that they didn't know they could, and brought to it in order to get it by a law enforcement officer, which is exactly what we all want. And it's something that I'm incredibly proud to have been a part of. And I'm really humbled to see how many people are here having this discussion. And I would just ask, in case I don't have any other time, that if there's something that you learned tonight that goes against maybe an idea or an opinion that you had, I would really just encourage you to tell somebody else about it, because I think that there aren't enough, as much as it's really great how many people are here. A lot of the people that maybe hold a lot of those stigmas and ideas are still out there and maybe aren't here. And that's one way that I think we can spread this in a way that will make a really big difference in the community. So thank you so much.
Great. Well said, Sara. And I got to say, I really believe in the power in the people in this room to help spread this knowledge. One thing that I've heard from many doctors, including Dr. Levine, is we have succeeded already in starting to change attitudes in important ways that impact this epidemic. Most patients, when they go to the doctor now, have an entirely different posture and relationship to these questions about whether they're going to go on to painkillers. I think that is a change, a cultural change that has happened because of conversations like this one, and I think we can do this in other areas as well, and it's needed. I continue to be stunned. I was on a panel recently, in which the remaining just again, anger and misunderstanding of this addiction and how challenging it is to fight continues to be very much part of what's out there, even here in Vermont, where there's been so much so much discussion of this already. Next, we've got Maureen Leahy, who's the director of the University of Vermont Medical Group, who has personally been very committed to much of what you heard of tonight in terms of the UVM Medical Center's response to this crisis, and has been at, I think, every community stat meeting and every Chittenden County Opioid Alliance meeting, and we welcome her being here tonight too, to share her perspective.
Thank you. I think one of the things that resonated most was one of my, I'll say, new colleagues' comment that we're responsible, we're accountable, and we need to do something differently. And as the academic medical center in this region, I feel fortunate that we are taking an approach. I feel fortunate to work for a place where we're taking an approach that we're responsible to a solution, we're accountable to finding a solution, and we need to be doing something differently. We've had many successes in the work that we've done. We're working on some things currently, and then we have a long way to go in other areas. So we've had some successes in decreasing our prescribing rates, which has been very impactful in this the work we've done. We've expanded some of our treatment programs with both the addiction treatment program, expansion of the hub and spoke, and then the new ED distribution program. And then we're working on some things that are challenging but are very rewarding to hopefully be able to add to the arsenal of ways that we're going to attack this. We have an alternative treatment model that we're working on standing up. I would say we're 75% there, and some of the things that have to change are in our health system, really, our payment models and recognition of alternative therapies that can work in place of opioids. And then, it goes without saying, we're the largest employer in the state, and it's incumbent on us to create a supportive work environment for people who are living in long-term recovery. And that's another body of work that's important for us to take on, to model and to lead for other employers who may not have the same resources that an institution the size of ours would have. And I think finally, the most important thing we need to do is to stop being okay with status quo. So when somebody comes up with an idea like, you guys should distribute buprenorphine from the emergency department, we can't be sitting up here saying, here's all the reasons we can't do it. We have to lead by example, and we have to figure out how to remove all of those barriers and help move this forward.
Chief Brandon Del Pozo, let's give that man a mic.
At your own risk. So when I became a police officer in 1997, it was because New York City was in the middle of a homicide epidemic where well over 2,000 New Yorkers were getting killed. I majored in philosophy. I didn't major in criminal justice. So you can say maybe I had a hard time finding a job after college, and I'm not going to comment on that. But I became a police officer to save lives. And if you look at the first job of American cops, it's to protect and rescue people in danger. The second job is to enforce criminal statutes. It's to collect evidence in people and bring them to a judge and a prosecutor. But I'll tell you, if you ever have to choose between saving a life or enforcing a law, and you choose to enforce the law while you watch people die, I question your motives as a cop. So one of the things I worry about when I talk to my peers, and I am a full-throated supporter of Sara George's decision not to prosecute for the misdemeanor possession of non-prescribed buprenorphine, is they look at me and say, this is a sheep in wolf's clothing. We have a guy here with a uniform and a gun and a badge and a baton, and he just wants to let criminals go by not enforcing the law. You know what? I've been very, very humbled by this opioid epidemic because more Vermonters have been killed under my watch and the watch of the public officials in this room than at any other time in Vermont history. And if the answer to that is to say, you know what I'm going to do? Just enforce the same misdemeanor laws that I've always enforced that have done nothing to save lives so far, then I wonder if we're fulfilling our obligations to the public. So we're going to go after drug dealers. We have a great narcotics unit. I have an officer in the Drug Enforcement Task Force. We're going to bring felony cases. I know there's a federal drug court judge in the room right now who we have animated conversations about the best way to hold people to account for making a profit off of destroying lives. But if you have something like a strip of addiction medication in your pocket, because you're not in the right headspace to say you want treatment, but you like the way it makes you feel. And clinically, it's a predictor of seeking treatment. And when it's in your system, the chance of you dying of a heroin overdose is almost nil. I don't feel like a sheep to say I'm not going to arrest that person. I feel like a wolf, like I'm going to be a guardian and save their life. And I just wish that my peers would understand that. My cops just do what I unfortunately order them to do, so I don't mean those guys. But I just wish that we'd understand the motives here. It's not to cede law and order, it's to make a difference, because this epidemic of death has been so incredibly humbling for police, because we tried for years and we haven't made a difference, but we're on the cusp of trying some new things, saving some lives, and I'm proud to be a part of that. Oh, sorry, Dr. Levine.
Now we have Commissioner Dr. Mark Levine, who I really want to express thanks to for being a great partner in the local efforts. We are very aware that we could not be doing the work we're doing at the local level without a full partnership from the state, and Dr. Levine has been the embodiment of that partnership in many ways. Again, a very constant member of these meetings and these attempts to stand up new innovations and interventions at the local level. So thank you for being here tonight, Dr. Levine.
Thank you, Mayor. Now, as the most official cleanup hitter, I can take it upon myself to offer some bullet points in summary, because you've heard so many incredible comments tonight. First summarizing point is all the law enforcement colleagues in this row have basically said the opioid crisis is a public health crisis. That takes courage, and that took a long time coming in the history of this country and in the history of this epidemic. And that realization alone has been very, very powerful. You've also heard this is a complex problem. And not only is it complex, it requires solutions that you never dreamed you would think of or even buy into. Things that sounded heretical are now standards of care. And the list of them is so long, you haven't even heard, you've heard the tip of the iceberg tonight. You've heard about science and evidence and how important that is, and it is critical, and we are amassing science and evidence at a really exponential pace here, because this field was a little bit behind originally. Nonetheless, there's areas that are less clear, more gray, that we don't have all the evidence in on, and the issue there is, are you courageous and innovative, or are you going to stand on the sidelines and watch more people die? And those are very challenging discussions to have. We've had one very challenging one locally and statewide with regard to safe injection facilities, and came out on the side saying, we're not sure that's the best place to put our resources now because we have so many other things going on. Got criticized by some, got praised by others, but that's just one example of how you have to actually think outside the box and decide where you can put your resources and where to be courageous. There's a common theory of change, for those who are familiar with how change occurs in a society, called diffusion of innovation. And it says that basically, originally, you just have a couple of innovators, and then you get the so-called early adopters that come aboard, and then eventually it kind of becomes a standard for the society, but you still have these laggards who never buy into it. Well, you're living in Vermont, and you're living in Burlington, Vermont, and almost everything going on in the opioid crisis is really on the early adopter and innovator end of the spectrum here. We didn't wait around for a long time. And just look at the corrections issues. In corrections, we were criticized widely for not buying into that early enough. Well, no other state in the country had until Rhode Island did. And we finally got some really good evidence from Rhode Island that this is successful. And now we've implemented it, and it's been a rocky course, but it's moving along very nicely. But that's the kind of courage that's required, the kind of innovation that's required. And frankly, it costs money to do these things. So people have to agree that this is a wise use of resources. Again, all in the effort to have less people die, have less kids put into custody, etc. You've heard about the importance of prevention, and prevention comes from the physician end with prescribing, and I'm happy to deliver the news that there's in the vicinity of 25 to 35% less opioid prescriptions being written, no matter where you look in the state right now, and that's true progress. You've heard that we need to have better payment plans for alternatives to opioids. The NIH is now starting to get more funding to actually do pharmacology research on drugs besides opioids, but we have a long way to go in the integrative medicine range of other therapies besides getting a prescription. This week and yesterday at the Governor's Opioid Coordinating Council, we heard some presentations from those who are familiar with the Icelandic model. And that's a prevention model that basically engages communities that are very activated, that want to see change, and want their youth not to develop into people who have substance use disorders. It's a great model. There's good examples of it going on in Vermont right now, even without calling it an Icelandic model, because we have really good, highly motivated communities. But the goal is address these very vulnerable young brains early in life, provide youth with the proper activities, especially in that dangerous after-school environment time, so-called third space, and you will succeed in reducing the rates of substance misuse. And by the way, we're confronting an opioid crisis, but the goal is all substances. And if you go to the legislature anytime this session, you're going to hear a lot of bills dedicated to that drug we call nicotine. And we should believe that nicotine is a part of the pathway to how people get into trouble, and respect the legislature for seizing that bull by the horn, and I think you'll see by the end of the session some very substantial legislation coming out regarding that, and the whole e-cigarette and vaping epidemic. I'll just end by saying, listening to people sounded so trite, it is so critical. We have always had at the CCOA and at the Opioid Coordinating Council and other coalitions around the state, the voice of people who have suffered from an opioid use disorder, to a lesser extent, but some extent, listen to their families as well. But if there's one thing we're learning now, it's we need to listen even harder and more. And if we want to be innovative, we actually have to ask people who have been through this, because they can actually help us understand how to be innovative. And their families especially can help us in that critical time period that we've labeled recovery, with all the issues that surround not just having the support systems you need to survive in recovery, but how to get a productive life out of it, meaning a roof over your heads, a job, transportation to your treatment centers, etc. Finally, the stigma, unfortunately, you've heard it by every person who's been sitting here. It has not disappeared. We're doing better. I always try to appeal to people's scientific knowledge, if you will, and give them a very, very rudimentary course in brain chemistry and neurobiology, because one has to understand how the brains of those with substance use disorders get hijacked by the drugs that we're talking about, and how that impairs rational decision-making in those executive functions that we all have in our brains, but that really don't play a role when we're lost in the midst of an addiction process. So the more that every one of us can share with others why we need to respect that is critical. Thank you.
All right. Thank you, Dr. Levine, for that summary, and I think especially your point about the importance of continuing to hear from people with lived experience and hear from the public is a great transition, as we are now going to open this conversation up. We have a couple of microphones up here at the front of the room, and we'll try to alternate from one mic to the next, and if you could quickly introduce yourself and share any reaction you have, your question. If you don't have a question for a specific panelist, I'll try to play traffic cop up here a little bit. Let's dive in. Welcome.
Hi, my name is Philip Pizeshki. I'm a licensed alcohol and drug counselor in South Burlington, and also a licensed clinical mental health counselor, dually licensed. I worked for 4 years in the Chittenden Regional Correctional Facility, working with the women, doing substance abuse counseling under the auspices of Phoenix House. It was my first job, and I quickly learned that I was not doing substance abuse counseling, I was doing trauma counseling. Because this epidemic is not, to my mind, about drugs. I really salute all the efforts that all of you and many of the people in the room have been doing about intervening at the drug and pharmaceutical level. But I'm afraid that that's a Band-Aid. A person's knee is bleeding, but their leg is off. And it's not going to really ultimately address the underlying problems to put a Band-Aid on that knee. I also happen to have been born and raised in Portsmouth, Ohio, which is where the book by Sam Quinones, Dreamland, is based. The reason, I think, in retrospect, that book was focused on that town, and the reason that the epidemic started in that area of Appalachia, northern Appalachia, is not only because of the pill mills and because of the black tar heroin coming in there, but because it was a depressed area economically and socially, riven by racism and devastated by unemployment. I know that addiction cuts across socioeconomic levels, but the idea that a person living in a tent and needs to receive medical treatment is really pretty disturbing to me. A person living in a tent needs to be in a house, needs to have a job, needs to have a community, needs to have the trauma that put them in a tent in the first place and led them to using drugs in the first place. The whole system needs to be addressed. Just one more comment, and that is that my clinical impressions at the prison were that there were essentially levels of addiction and choices of substance that my patients, that my clients availed themselves of based on the kinds of trauma that they had experienced. I don't have any research to back this up, but basically, women who had suffered emotional abuse would drink and use marijuana. Women who had had physical abuse would use things like marijuana and cocaine. The heroin abusers were almost by and large sufferers of sexual abuse. There is an epidemic of trauma and abuse in this community. And again, while I applaud the efforts of these people and all of us to treat this as a medical issue, it goes far beyond that. And if we really want to take a public health approach, then we need to take a public health approach and not just a medical one. Thank you.
All right, thank you. So I think that's a helpful question for framing things up here. Josh, do you want to address that, or does anyone in particular want to weigh in that? Or sorry, Grace, you were making a motion. Go for it, Grace.
What I can say is I agree with you around trauma. I do believe that the trauma is often the gateway drug, that most of our clients are facing trauma. But what we're doing is getting people in the door and getting the medication immediately to save their life. We also have a team. So we have social workers, we have case managers, so that they won't be living in a tent, so that they will be addressing their trauma. So what the attention tonight and focus was to get access to these medications that will save their life. We have these wraparound services that are client-centered, that are focused on what clients need, and we will be working directly with them. Each person will get a case manager and a social worker, or is getting a case manager and a social worker. So we're really fortunate to have a large SAMHSA grant that's allowing us to wrap services around those people very tightly.
I think you've raised a really important perspective that I think is widely held, and I think is one for us to grapple with. I have to say, I don't fully agree with that diagnosis of the situation, in that I don't think there has been an epidemic of hopelessness and trauma since the mid-1990s. I think there's been an epidemic of the availability of opioids, and and there's a lot of, I believe, science to back this up, has more than anything else driven the overdose deaths that we have been very focused on here in this community. And I I think when we start to think of this as just one more symptom of America's problems with poverty and trauma, we actually only see part of the story. Certainly poverty is part of it, and I think people who are in poverty face a tougher challenge in getting their way out of an addiction, but I'm actually stunned with this crisis, the degree to which it does cut across all socioeconomic classes and the degree that it does touch everyone. And I think that that actually is more alarming when you think of it that way, and should cause us to take, there are many things we don't respond to adequately when it's seen only as something that is sort of a symptom of these other problems. And I think we will lose people if we don't respond to this as a hot public health crisis that we can do something about, and where fixing some of these structural problems, which clearly exist in society, I think if we wait to fix them, to do anything about the opioid epidemic, we're going to lose a whole lot of people. And I think a lot of us up here come from the perspective that we can actually save a number of people and are starting to save people in communities across the country. So let's go over here.
Thank you. My name is Ada Pouchet, and I do outreach and education work for Champlain Valley Dispensary, which is one of the state's medical marijuana dispensaries. And I just wanted to share some observations about cannabinoids that can be helpful in this conversation, both non-intoxicating CBD that people have been using for pain relief, and the combination of THC and CBD, which also can be non-intoxicating, and that people are using to address withdrawal symptoms. And also just to mention that several states now have added opioid addiction and chronic pain to the list of qualifying conditions for their state's medical marijuana programs. I'm just curious if anybody has any thoughts about that they want to address.
Yeah, so thank you for your comment. You know, the National Academies did a really comprehensive review of the evidence, did not find any evidence that would support the use of marijuana for treatment for opioid addiction. I think more in a grayer area is the question of whether the use of marijuana for pain might lead to less of a problem, and I would say there the evidence is more mixed. So there are some studies that suggest it might lead to less use of opioids. There are other studies that suggest people who use marijuana might be more likely to get into trouble with the opioids. So I think that's a more complicated question that probably further research will develop. But in terms of treatment for opioid addiction, my sense of the evidence is, and the National Academies, which is, did a thorough review, is that people are much better off on effective medications that have been proven than any medication, including marijuana or others, that have not been proven to work.
Excellent. Welcome.
Hi, my name is Miss Jackie Robertson, and I've been a citizen of Vermont for 15 years. I'm the maven of Battery Park and the bitch of North Champlain Street. And I'm the other side of this story, okay? I have a failed hip replacement that neurologically has been causing me agonizing pain for the last 2.5 years. And I can't get anything opiate-based to help me manage it. And I know it works, because when my best friend died, she gave me her Vicodin. And I spread it out over 6 months and only took it on the days when I didn't want to go to the emergency room. I got my first Suboxone patch today. Okay, I was fucked up out of my mind in the cemetery talking to Brenda this afternoon for 1.5 hours until I could finally get home in one piece. But I'm here to testify that it ain't cutting it. But the Vicodin did. So I'm the other side of the story here. People that have chronic pain, and if it's spinal, or usually that's where it originates, but not with me. People that have chronic pain are no longer being able to get access to anything opiate-based. And people that have had their chronic pain managed for years with morphine and opiate-based pain relievers, it's a godsend to them. I can't work anymore. Sometimes I can't even make a cup of coffee for myself in the morning. And I have medical marijuana. I spend $500 a month or more on pain management, and it still doesn't cut the mustard. And if I have to buy it at the state dispensary, then I'm giving all of my what I can't even afford my car insurance. God, I hope I can next month. I'm giving all my living to the pot dispensary, and their pot isn't consistently effective. Thank God I have friends that grow it without putting chemical fertilizers in it, but it's not cutting the mustard anymore. So, and I have friends that have to, I have a friend in California, she said, well, I can't, I have Kaiser, I ate a pot gummy bear, so they pee tested me, so they're saying I'm a drug addict, so I have to save my opiates until, for the end of the month, I have to go without pain relief, because I want to have 10 more to get me through, because I got to argue and fight for them every single month.
Okay, thank you. I think
And
your question is
if I
clear.
had adequate enough pain management, I could work for a living.
So,
Okay.
thank you. This is a question that comes. Yep. All right, thank you for this question. A very important question, and one that does come up whenever we have these discussions, and I think the speaker speaks for a lot of people in those frustrations. Could one of the doctors kind of weigh in on how we try to get this balance right?
Here, doctor.
I'm not a doctor either.
This story is not an uncommon one, and we need to have tremendous respect that she had the courage to get up here in front of an audience and talk about it. There's an increasing medical literature, very current medical literature, looking at the fact that there's a cadre of people, rather large cadre in the country, who have been maintained on chronic opioids for chronic pain and seem to be suffering from, if I could use such a strong term, abandonment. Pharmacy program managers, health plans, individual physicians, you name it, now more reluctant to continue to provide those opioids. We cannot condone abandonment by any means. We can condone such things as compassionate tapers and also integration of other forms of pain management. So it needs to be the entire package. And we need to approach each individual with the sensitivity and compassion they deserve. I will say from the other end, though, before the person gets their first opioid prescription, we need to be very mindful of scientific evidence that informs us that this is not the most optimal form of chronic pain management. And in fact, it actually doesn't work well as chronic pain management. Most of the efforts you've seen in terms of the Vermont prescriber rules and use of prescription monitoring systems are by and large focused at that first prescription for someone with acute pain, knowing that even the risk of that one prescription in the first several days can provide a higher probability that an individual who came in opioid naive and just got their one prescription would then actually remain on the same drug 6 and 12 months later, or even years later. So we need to be very mindful of the evidence that for chronic pain management, this is not something that we should be routinely doing in medicine.
Welcome.
Hi, my name is Amanda Falcone. I am a graduate student. I'm getting my PhD in clinical psych at the University of Vermont. I'm also part of a group that treats substance use disorders among federal inmates at Northwest State Correctional Facility. It's pretty apparent, and you have all made comments that articulate how, unfortunately, substance use and incarceration are pretty intertwined. You, Chief Ryan, you mentioned experiences arresting the same people over and over again, and I'm wondering, in our experience working with those who are in the facility about that really fragile time post-release, when these people are going back into the community, they're very sensitive, maybe they haven't used in a really long time, they're suddenly confronted with the context, the peer groups, the drug cues that they had been avoiding or had been unable to see while they were incarcerated. I'm wondering what suggestions you all have for community providers to help mitigate re-engaging in substance use, overdoses, or criminal offending in that time.
Great, Amanda. You've struck on, I think, one of Vermont's real success stories over the last, call it 8 or 9 months. Vermont has really been focused on exactly that question. Dr. Levine, would you like to speak to the efforts at I don't know if we've done justice tonight to the kind of full extent to which the state is really attempting to address exactly that question.
I have to be honest, I was
Okay, sir, the question is basically, can you describe what is happening for the incarcerated population in terms of access to medically assisted treatment, and then specifically what is happening in terms of a warm handoff when people are leaving incarceration to ensure that they don't immediately, during that very vulnerable time, that they don't become an overdose victim?
Sure. So on any given day, there's 1,700 individuals in our systems across the state. And somewhere in 600 to 700 range are the numbers that are actively on some form of treatment. About half of those were already on treatment before they entered the system, and that's being continued. The other half are being initiated. It's always been thought that the most important time juncture is the day of release, because that's where the highest risk of overdose death is associated. So a lot of attention has been placed on just that moment in time. There are people who have actually been imprisoned for years that may not be on medication-assisted treatment after they've been medically assessed and screened with some accepted screening instruments. Those individuals, though, still may be at very high risk when they leave the correction system. Everyone is offered, though not everyone accepts, a dose of Naltrexone. It's the one drug we haven't actually mentioned tonight. It's called an opioid antagonist, meaning that it's different than the drugs like methadone and buprenorphine, which have agonist activity, which means that they act like the drugs that you're trying to prevent people from taking. But it's a very effective tool for someone to have at discharge. But equally important is this warm handoff concept that has been referred to, because the treatment system needs to be arms open, appointment ready, person not at risk for falling through the cracks. I'm not a member of the corrections department, but at the same time we've worked really hard on just that concept, and I would like to hope and think that that is working very well at this point in time. I can't give you any of the data from them at this point in time, but that's really our goal. And even within the treatment system, within corrections, there are some individuals who have been offered and accepted Naltrexone, usually those who have been free of opioids for a number of years because they've been in the safe environment of the correction system where the drugs were not circulating. Does that answer what specifically was asked?
I think that's great, and it is that is a metric that a lot of people are really focused on to ensure that there's a real awareness that the chance of overdosing and dying in that period is much higher than at other times, and we've all been impressed by one of the things that motivated Vermont's efforts is an awareness that in Rhode Island they saw the accidental overdose death rate cut through these very progressive prison reforms, and we're trying to replicate that here in Vermont, and I think there's a lot of people watching to see that is exactly that is done well. So, welcome.
Hi, my name is May Chow, and I am a mother. And so you're looking at these young kids. You know, you talk about this epidemic, it's not getting better. It's not like the population of this epidemic is going down. How are we going to help our kids not to fall prey to this epidemic? Because I mean, I hear, you know, we've got the resources, hey, let's get them treatment and all that, but don't we need to talk more about prevention and making these kids understand, hey, these are the consequences, and not glorify it like these people that are out there dealing it. I mean, hey, they get caught with it, okay, well, you know what, the money and the prestige of being out there selling this stuff to these poor addicts, I mean, we need to put more pressure and punishment on these individuals so that when they do serve a little time in their little punishment, what do? They go back out and they start dealing again. We need to stop that accessibility for that, and especially for our kids. I mean, that's what I'm really worried about is our next generation that's growing up.
Excellent. Great question. I think it hits on a couple key points. Maybe someone from law enforcement here, I think, try to speak to. I think there's a lot of sympathy for what you're expressing. There's nothing about Burlington's response that doesn't believe that we need to be going after people who are doing significant amounts of dealing. Chief or Gil, do you want to go?
Mention, I think prevention is really the missing leg of this four-legged stool. Recovery is very separate. There hasn't been any comprehensive work done by the Department of Education, and that goes back not just the Obama administration, the Bush administration. Currently, President Trump has said that there's going to be a large prevention campaign. I don't think I've seen it yet, but we haven't done anything since the DARE program, which was, of course, evaluated and shown not to be very effective when it came to preventing young people with drugs. So quite frankly, you need to start early with a age and curriculum that's specific to the grade. That's part of the healthcare process. You can give parents information, for instance, the Partnership for Drug-Free America, their website and others that help parents. But frankly, we spend a lot of time in schools, and my daughter's a third grade teacher, being able to teach kids a lot of other things. We should be teaching them about prevention. And I think I wholeheartedly support what you said. It's missing, and I think it needs to be reinvigorated.
Chief Ryan.
Thank you. And I would just add, if I didn't say it at the beginning of my presentation, we take our responsibility to seek out and prosecute and work with our prosecutor's office to prosecute those that would profit from somebody else's addiction. One point I wanted to make is that in our jurisdiction, many of you may be familiar with drug asset forfeiture funds. So if we seize the funds from a drug dealing enterprise or individual, it goes into a law enforcement account. In our jurisdiction, we use those funds. Now, think about karma here. There's my Boston accent. Think about karma. We use those funds to fund prevention programs and our embedded clinicians into the police department to help provide services from those suffering from addiction. So a lot of that work is going on in jurisdictions throughout America.
Josh.
Yeah, I was going to respond in a slightly different way, which is that on these issues, which can become quite emotional, it's very important to take a step back as much as possible and look at what evidence is. If we want fewer kids to use drugs, where is the evidence of what works to help prevent kids using drugs? And one of the most important statistics for me was that most kids who have trouble with drugs are having trouble with school first. It's overwhelmingly they're having trouble with school, and they're getting into a whole range of different issues. And helping kids succeed in school is one of the most important things. Second thing is a stable home. And kids who are in very difficult home situations are in very high risk of being traumatized and having all kinds of issues that lead to drugs. And so when we think about the challenges, we want to help kids' parents get into treatment. We want to make sure that kids are doing well in school. And as much as we might want it to be true, arresting a lot of people is not actually something that has been shown to reduce kids using drugs. And in fact, countries in the world that do not arrest practically anyone for using drugs have declining rates of youth use, in part because people who are using drugs get treatment quickly, families stay intact, and you don't have these cycles that can perpetuate school failure and drug use.
Just one quick point. I did hear a plea for prevention in that question as well, not just enforcement, and a sense that what's going on out there to tell our kids what's right, what's wrong. You need to know that from at least the public health department strategy viewpoint, there are messaging campaigns going on that parents in this room have no idea about because they're not directed at them on the 11 o'clock news. They're directed to the social media and the age group that social media uses. And so you may never see them, but there is certainly messaging going on. But in addition, to meld the mayor's plea about the opioid crisis regarding pills prescribed in clinicians and our mental health and licensed alcohol counselors' concerns about our society, there's a whole bunch of things that are in prevention. One of them actually is having nurse practitioners visit homes at the time someone's pregnant and about to deliver or has just delivered, because all those what we term adverse childhood experiences and adverse family experiences that are present get diagnosed and referred to resources at that very early time in a kid's life. You also heard me talk about Iceland and prevention models that really focus on the after-school third space. And then there's the whole issue of schools, and we have many schools that have excellent curricula and substance abuse professionals in the schools who connect with the kids very well. Do we have equity throughout the state? No, and that's one of the charges we have now, is to try to make that universal across the entire state.
Great. Brenda's question, I sense, could be on that topic.
I'm Brenda Siegel, and as many of you know, the day after I decided to run for governor this summer, my nephew died of a heroin overdose, and he was the son of my brother who died 20 years ago of a heroin overdose. I can't quite express how many times a day I say I don't want to be running around this state advocating for change on this issue. It is not what I want to do. It is extraordinarily painful for me. So I just want to share that when Chief Del Pozo was testifying in House Judiciary on H-162, which is the bill that decriminalizes misdemeanor amounts of non-prescribed buprenorphine, he was asked if it would make it both, that this legislator was concerned it would be both valid and respectable to use buprenorphine if the misdemeanor crime was no longer. Brandon paused, this was my experience of it, looked directly at this legislator and said, well, the ingestion of buprenorphine is both valid and respectable. At first, I thought that I felt a calm in my body and a relaxation and a letting go, because that was greater than I had the day I heard my nephew died. And then I realized that I hadn't felt that calm since the first day I knew that he was suffering from this disease, because I knew that he and many of you are fighting for safety for people and willing to utilize the most current science to make this change. I want to really congratulate Burlington. I live in the southern part of the state. In my county, while deaths went down 50% here, deaths went up 60% in Windham County. And that doesn't include my nephew who died in Minnesota or people that died across the border, and we are on the border of everywhere. And what really makes me have a challenge when I'm advocating is not embracing what Chittenden County has done to reduce death. Because I cannot describe to you the desperation of being a family member in that county where we don't have low barrier buprenorphine, where we don't have induction in the emergency rooms, where we do not have easy access to buprenorphine and to medical treatment. Even though we have the retreat right there, we still don't have easy access. And the number of times my nephew got kicked off, which led to relapse. When Maple Leaf closed, it led to relapse. When he was kicked out of sober houses because they didn't take medically assisted treatment, it led to relapse. When he was prosecuted, it led to his death. And what I want to say is that what we need to be saying when there is a bad batch of heroin is choose buprenorphine instead. We know that it indicates a pathway to treatment, and I'm really concerned that the administration has not embraced that, because that is going to be a life-saving measure. And for families like mine, we don't have time to fix this. For families like mine, we do not get our loved ones back.
Thank you, Brenna. I think we have time for just one last question, and then if anyone would like to respond to that, we can do that. I think the point was very clear. Erin, welcome. Sorry, welcome.
Hi, I'm Jess Kell. I work for Lund, and I'm the Kids Apart Parenting Program Coordinator based inside the Women's Correctional Facility, where I've been for the last 11 years. I deeply appreciate the efforts towards saving lives. I can count too many clients. Just today, I had a client in my office, and we were chatting, and she said, "Hey, did you know about so-and-so?" I've attended too many funerals of clients. That piece I deeply, deeply appreciate. I also want to validate the comments that Philip made about trauma. And I very much, what you talking about ACEs and adverse childhood experiences. And I really want to speak to family-centered treatment that's gender-informed, as well as we need to meet the needs of children whose parents are suffering from addiction. And I do want to strongly encourage that we continue to advocate for social workers in our schools to deal with trauma, after-school programs, and it's not just low-income people who are suffering from trauma. Sexual abuse happens in every economic level. And while substance abuse can affect anyone, people who have experienced trauma from every economic level are far more vulnerable than those who haven't. So if we're going to stop this epidemic, we have to save lives, but we have to make sure that we're taking care of the kids in this community and meeting their needs, and that we're funding programs that do that. Thank you.
Okay. Well, I want to say we're going to do two last things to finish up tonight. First, I want to say thank you to the panel, and particularly our national experts who've traveled here to be a part of this remarkable day and are going to be with us again tomorrow, speaking to 160 members of law enforcement. And we really appreciate you taking the time to come to Burlington and be part of this conversation. And thank you to everyone else up here for giving their evening and committing so much to this effort. And then last thing, I believe Christine Johnson, who is the executive director of the Chittenden County Opioid Alliance, which is, and here she is going to just leave us with some final thoughts on where this conversation goes from here.
Great, thank you, Mayor.
Thank you, Christine. Thank you for everything you've done in this challenging role that you've really figured out how to have an impact in this community.
Great, thank you, Mayor. All right, well, I know it's close to 8 o'clock, and so I want to be brief in my remarks. But first, I want to tell you, as the executive director of the Chittenden County Opioid Alliance, just what an honor it is to be in a room with such compassionate people who are really leading this work, people who are really helping shepherd and steer this work. So thank you to this panel, to our national experts, but thank you to all of you for being in this room. For those of you whose lives have been touched, as many of you have spoken tonight, I honor and I salute you, and so does everybody sitting up here. That the reason that we do this work is because we don't want to lose another person in our city, in our state, or in our nation, anywhere in the world to this horrible opioid epidemic. So thank you for joining us. But what I have to ask of you is that what we know from the Chittenden County Opioid Alliance's perspective is that none of us alone can answer this call. Not one organization, not law enforcement, not the health department, the state government, local city government. We all have to be in this together. So if you're interested in coming and doing work on this epidemic, please join us. And we meet every second Friday at First Congregational Church, and we do some action team, some strategic planning, take a look at the data to really drive what it is that we're doing, and really try to systemically approach, in conjunction with community staff that you've heard a lot about tonight. We are really working to think about how do we address this across Chittenden County, and we need your help. We cannot, like I said, we cannot do this alone. So we heard tonight, this is a complex issue. We all know that. We need to lead by example. I heard that tonight, and that really resounds with me about what we can all do individually. This is going to require solutions that we haven't even dreamed of. I loved that perspective. Things that are very out of the box, they're working here. We're seeing that in the reduction in our overdose deaths. We know that we need to support our families, that we have to do better by our families, by our children. We have to address trauma, and we have to address prevention. So this isn't everything under the sun, and that is why we need you to join us. How do we move this work forward? Really, again, we do it with all of you. We do it in every sector. We do it by addressing stigma at the dinner table, at the professional table, and everywhere that we go. We have to do exactly what you heard tonight, which is lead by example. I want to thank you for being here. I want to thank you for having such great partnerships. Again, such committed and dedicated people who are really willing to wake up every day and make our city and our county and our state a better place. So thank you so much for being here.
They would check me at school.
Administrative Director for Neurology and Psychiatry. Infiltrated Addictions Program.
It's a little easier to get up.
Any primary care doctors?
Yeah, actually, we
Good God, from below?
expanded our. That's a terrible spoke model. So every clinic that we have has primary care prescribers. Yeah, it is.
Thank you so much. It was great. See you the other morning.
Yeah.
Oh, okay. Well, I'll see you there. That was great.
She was exhausted. I was more exhausted than there. So done. She's by me.
Just trying to get back.
Yeah, right. It's like, oh, I gotta get there for lunch. That was that was the last one in. Gotta get there for lunch.
That was good. Hi, Maria.
Nice to see you.
I was not in
Thank you very much.